be pretty well set up and ready to go.
So Zoom would be connected or Bluetooth?
Yeah, sorry. I'm going to share your screen.
Oh, you are? Okay, great.
So we can get the slides loaded okay. I think it's right here, but I don't know what that is. This one here. Didn't hear a ding. Here. Yeah.
I have it in my email as well.
Wish. Sorry about that. Yeah. Last stitch of it.
Yep. Need to format. Did I find it?
No.
No.
Okay. Yeah. You'll need to get it from email. For whatever reason, this is lightning. Yeah. The Chrome won't work.
Outlook.
Yeah, that's actually.
They still can. Did I download this?
Right. Then you go to drag it onto the desktop, or you can open it. Yeah, that's totally fine as well. Okay. You just need to reset this thing. Close that. Pick that up. And hopefully you're off to the races.
Excellent.
That microphone is actually still
Okay. And so when I'm done with the slides, I just stop sharing and they'll be able to ask me questions, etc.
They should come over the. Let me double check the speakers really fast, but they should be. Not a good sign. Not the best. Here's something. That sounds like somebody unmuted. Yeah, there's one person unmuted.
Oh, hey, Carrie, can you hear us?
Hi.
Hi, Carrie, can you hear us?
Yes.
Oh, excellent. Great.
Okay. I think you are now finally off to the race. Sorry about the computer.
Says Lily is talking, but I can't hear her.
What was that,
Can you
Dr.
hear-
Emma?
Can you hear me? I'm out at Mary and Elizabeth. Sorry.
That's okay. We can hear you.
Okay. Let me know when you want to start.
I'm ready whenever everybody else is. I think we can give them just a few more minutes.
Sounds good.
Are you able to see the screen, Dr. Emma?
Yes, yes.
Okay, good.
I'm going to go out from this and try to get it on my laptop. Be right back.
Sure.
Can you hear me?
Yes, I can. Can you hear me?
Yes, I can. I just couldn't get it on my laptop, so I'm having to use my phone. But
Okay.
I can see your screen really well. Are
Cool.
we ready to start?
I think so. Not sure how many
Okay.
people have joined in, but I think we're ready.
Okay.
All right. Well, good
Okay,
morning, everyone.
Dr. Hassan, I'd like to introduce you.
Okay, sure.
Yes. Good morning. Welcome to Grand Rounds. We're very excited to have Dr. Saad Hasan, one of our new faculty members, provide us with updated information on the evolving concept of embolic stroke of unknown source. Dr. Hasan comes to us from Harvard and is very, very well versed in this area. We've loved working with you, Dr. Hasan, and we're looking forward to this Grand Rounds. Thank you.
Thank you so much, Dr. Emil. That's a kind introduction. Those of you who I haven't met, I'm really looking forward to meeting everybody soon, but just wanted to take a moment and thank you everyone for welcoming me here and making the transition a really smooth one. So when I was asked to give this talk, I just sent out an email saying that I'll be giving a talk on ESUS. And immediately I got a reply saying, what do you really mean by ESUS? So that was bad on my part. ESUS really stands for an embolic stroke of unknown source, and it's quite self-explanatory. It's really strokes that even after significant testing and workup, the cause really remains unknown, but the stroke is obviously coming from somewhere. So without any further delays, I don't have any disclosures or conflicts of interest. So everybody here, we do have a couple of people here in the room as well, and people joining in virtually, really know already that stroke is one of the leading causes of morbidity and mortality worldwide. Generally, we classify strokes into two categories, and that's just an overall classification. We'll dive into a more detailed one in a bit. So strokes can be due to ischemia or hemorrhage. Ischemia can occur due to either thrombosis, embolism, or a generalized hypoperfusion event, while hemorrhage can be bleeding into the parenchyma or into the CSF spaces when we notice it in the subarachnoid hemorrhage cases. So brain ischemia can really be due to one of these three pathophysiological causes. So it's really important to know what this could be to understand eventually what ESUS is. So it could either be an artery problem itself locally, where either a plaque can develop or cause some sort of an obstruction, thrombosis, could be secondary to atherosclerosis, a traumatic event like as in dissection, and again, it can happen either in the large or the smaller vessels. Again, the problem is really within the vessel itself. Embolism, on the other end, really means that the problem is originating elsewhere, and it has broken off from the original issue, and then it has gone up to block another artery more distally. Most often we see in strokes, embolism usually comes from the heart, or in cases, even thrombosis can then present as embolism, where a clot can break up from the artery itself and go distally, and that's what we call an artery-to-artery embolism. Systemic hypoperfusion, where patients may be anemic, have low blood pressures, hemodynamically unstable, and that can cause low perfusion and ultimately lead to ischemia, which is quite distinct from the other two mechanisms. Talking about the incidence of stroke, so globally, intracerebral hemorrhages account for only 28%. Ischemic strokes are about 62%, and subarachnoid hemorrhages are about 10%. You see more hemorrhagic strokes and subarachnoid hemorrhages in patients or in countries or areas with low and middle income or still developing. In the US, however, ischemic strokes accounts for about 87%, 10% of hemorrhages, and about 3% of subarachnoid. So when I was a medical student, I always used to think that the toast would probably be a mnemonic for something, but unfortunately it isn't. It's really a generalized or a very general or a broad classification that we use very commonly in basically denoting what mechanism of stroke could have occurred, and we're distinctly talking about ischemic strokes here. So the strokes can happen either due to large artery atherosclerosis, can be cardioembolic, can occur due to a small vessel occlusion. Most often we see in patients who have significant vascular risk factors, diabetes, hypertension, dyslipidemia. Strokes that do not classify in the above three categories, but we know what caused it. Could be dissection, could be fibromuscular dysplasia, some sort of an infectious etiology. So all of those fall in the fourth category. And the final category is basically what we're really interested in talking about today, where we don't really know what caused it. And why is it really important to know the stroke mechanism or the pathophysiology behind individual patient stroke is that really the treatment is directed towards the etiology rather than the stroke itself. So it's really important to know the mechanism, because that would really help us in decreasing the risk of recurrence of a new stroke. Just a graphical representation of the stroke subtypes. So specifically talking about the states, 88% are ischemic, 10% cerebral hemorrhages, and 2% subarachnoid. Out of the 88% that are ischemic, more than 50% are non-lacunar. And when we divide those further, about 35% turn out to be cardioembolic, and a huge chunk, about 45% of them, we don't really know a cause, so they fall in the cryptogenic territories. And even off those cryptogenic territories, about 50% are embolic stroke of unknown source, and 50% are caused by other unknown sources. Interestingly, the annual incidence here of stroke is about 795,000, of which about 610,000 are first-time strokes. Now, this is old data. It's about 10, 15 years old. And interestingly enough, about 185,000 strokes are recurrent, which is still quite a big number. And the epidemiology is really divided into different regions. We fall in the stroke belt, and we tend to have a higher incidence of stroke and a higher stroke mortality overall as well. Our colleagues in Cincinnati, Dr. Broderick and his colleagues really did a very interesting observational study a few years ago, looking specifically at our region and trying to find out what sort of strokes do we usually have. And turns out we are really good in having small vessel strokes and strokes of undetermined source, or cryptogenic strokes basically. And again, black population as compared to white ones tend to have more large vessel strokes. Could be secondary to underlying, differences in their vascular risk factors, diabetes, hypertension, and all of those factors. So with that, I would just try to turn our attention more clinically. Just wanted to present a quick case that I had in my fellowship in Boston. A young guy, 30 years old, presented to us for an evaluation of right-sided vision loss. He was walking his dog around 8:30 in the morning, noticed that his upper half of the vision in the right eye was grayed out. Lasted for about 5 minutes, and when he closed his left eye, when he closed his right eye, he could see fine through the left, but the real problem was in the right eye itself. So after 5 minutes, however, the vision seems to have changed, or the vision changes really went from upper half to the lower half of the visual field, and now that part was grayed out. So he did have a history of migraine with aura. His auras were really described as flashes of light, the typical migraine features that you see that were followed by a headache. And he used to experience them not too often, just 2 to 3 times a year. What brought him to the ER this time was that his vision was never grayed out, and it was always bright flashes of light that he used to experience with his migraine. He did have a history of a prolactinoma that was diagnosed back in 2015. He was on therapy for that, and when they did a repeat MRI in 2019, it was no longer visualized. When we examined him, he had a significant right lower field cut. It wasn't homonymous. No other focal deficits, no speech disturbance, no sensory changes, no weakness, numbness in the arms or legs. Did a CT, CTA, head and neck. Both of them were pretty unremarkable, without any calcifications, no vessel occlusion, nothing that we saw in the PCA territory itself either, or the carotid. So this is interesting because we usually get these patients quite a bit in our ER where they do have history of migraine with aura, and then they're coming in with either hemiplegia or some vision loss or vision blurring, and then you're not sure what to do with these young patients. So my theory is always that I tell all the residents to do is that, if there's a disabling deficit, like in this case, you have to offer TPA, even if you're leaning towards a diagnosis of migraine or not vascular. I would still offer TPA. I would discuss the risks and benefits. I would discuss the 6% bleeding risk, and let the patient decide what they would want to do. Because the next day when the MRI comes back positive for a stroke, then you'll probably be kicking yourself. But in this case, his NIHS was low, definitely, but it was visual. It was a disabling event. I did offer TPA, but he refused. He thought that he was getting better, which was, I guess, reasonable. We got an MRI, did not show any acute stroke, got an ophthalmology eval in the ER, and that also didn't really show any signs of a branch retinal occlusion or a central retinal artery occlusion. He did improve, however, some of the visual field deficit did persist, and then he left home and requested outpatient follow-up. So he did see ophthalmology 2 weeks later, and he did have a branch retinal occlusion in that eye. Saw us in the clinic later. We placed him on a cardiac monitoring. No runs of AFib. He was 30, so the likelihood of this being AFib related was low. Hypercoagulable workup, TTE, didn't really do. We just proceeded with the TEE, and it showed a large PFO. So why I wanted to present this case was a little challenging initially with the acute treatment, and now once a PFO is found, what do you do with it? So we're going to discuss that in more detail. Sorry, I'm on call. I'm getting some messages. So cryptogenic strokes, and I will use the term cryptogenic stroke and ESUS stroke interchangeably. They form about 40 to 45% of all ischemic strokes, so quite a big number. I actually didn't know that there's actually a cryptogenic ESUS working group which really sits annually and comes up with guidelines and comes up with recommendations on how to work these patients up and how to manage these patients. Basically, they define cryptogenic strokes when no other cause is identified and on baseline workup. What do they include in their baseline workup is really quite a plain workup, to be honest. So just a transthoracic echocardiogram, imaging of the cervical and the intracranial arteries, a 12-lead EKG, and a 24-hour of heart rhythm monitoring. That's basically all you need to classify a stroke as cryptogenic. Obviously, when we dive in and we do a further workup and we do end up finding a cause, things change, but that's all you need to define a stroke as cryptogenic stroke. Now, we routinely do hypercoagulable workup, obviously according to the appropriate clinical setting. We do place link monitors, we do TEEs, but that is generally not required to establish a diagnosis of these kinds of stroke. They really divided cryptogenic stroke into 3 groups and really did not really make too much of sense to me, but doesn't really help with the classification too much. But what I really wanted to define was the ESUS strokes, which are really non-lacunar on imaging. So what is non-lacunar strokes, and this is really important to note for the residents, is any stroke that is more than 1.5 centimeters or 15 millimeters on the head CT, and more than 2 centimeters on diffusion restriction or diffusion MRI. And again, that's the size of the stroke that classifies it as ESUS, and then again, the basic initial workup should be negative, including 24-hour rhythm monitoring, CTAs for carotid and carotid stenosis or MCA stenosis, and EKGs and all of those things. So it is quite a big number. About 17% of all ischemic strokes eventually turn out to be ESUS. And why is it really concerning is because even the standard antiplatelet therapies that we do these days for these patients, the annual rate of recurrence is really high. It's still about 4.5%. So there's something that is definitely missing with ESUS strokes that we're not able to capture now. Maybe it involves more rigorous imaging, more rigorous testing that we need to do to basically figure out why these patients have such a high risk of recurrence. Would highly encourage residents to read this recent literature, specifically because it's coming from me as well. Our colleagues in Boston, we just recently published this in the Treatment Options in Neurology. It's a very comprehensive review of ESUS strokes. I would highly encourage everybody to read this, and I can send it out if you guys need it. So even though ESUS really means that we don't have a source of the stroke, there are certain potential sources. There has to be a potential source. And what are those sources? So cardioembolic source is eventually found in about 15 to 30% of patients who end up having ESUS initially. And out of these cardioembolic sources, atrial fibrillation is the most common one. And atrial fibrillation can be sometimes challenging to pick up. So you may not find AFib during the hospital, say on regular telemetry monitoring. Most of the studies have proven that the longer you monitor the heart, the more chances you have of picking up atrial fibrillation, with some discrepancies, but that's the general notion that we have. Crystal AF study, or the trial that was done in Canada, really showed that the chances of picking up AFib can be as high as about 30% if you monitor the heart for about 2 to 3 years. And then apart from atrial fibrillation, other sources of embolism or cardiac embolism can be a left ventricular thrombus, which we do commonly see, an ejection fraction less than 35%, some sort of a heart tumor, some mechanical or prosthetic valve issues, a prior MI, aortic arch atheroma, infective endocarditis, and we'll talk more about PFOs. So these are some of the other cardiac causes that can happen as well. This is a million-dollar question, right? Because PFO is really common in the general population. About 15 to 25% of general population has a PFO. If a patient ends up having a stroke, is the PFO the cause? That is something that we've been doing a lot of clinical research and studies on. And still the data is unclear, but we're, I think, reaching there regarding the causality of PFO and stroke. So specifically, PFO characteristics are really important to note. How large is the PFO? What's the extent of the right to left shunting? What's the morphology? Does it have a septal aneurysm and other factors which will place the patient in a high risk category? Atrial cardiopathy is another potential source that has been worked up more recently now, and it's thought to be may be a potential cause of atrial fibrillation as well. So pathologic changes in the left atrium like fibrosis, impaired contractile function, and hypertrophy, all of these things can happen and cause cardiopathy. And could this be a possible mechanism through which a clot can form and go up and cause a stroke? And this is being looked in one of the studies that I'll talk about more in detail. And out of all these, obviously atrial fibrillation is one that we commonly see, but more recently, more studies and clinical trials have started to look into these carotid plaques as a potential cause of ESUS. Why is that? Is because numerous observational studies have shown that patients who we think are ESUS, when we look at their vessels in more details, they tend to have plaques in their carotid arteries that are ipsilateral to the stroke, especially plaques which have high risk features, like, for example, if they're ecolucent, if they have an intraplaque hemorrhage, a lipid-rich necrotic core, or, for example, a mural thrombus, they tend to be a very or like a potential source for these embolic strokes. And when they follow these patients with prolonged heart monitoring, these patients tend to have lower incidence of AFib in one of the studies that was done. So could this be a potential source? I definitely think it may well be, but you need to have some plaque features which will suggest a higher risk of embolism than just a normal calcification. Again, a Canadian study that presented this case in their trial. So if you see in images B, C, D, and E, you can see pre and post central gyrus embolic looking restricted diffusion with ADC correlates. And when they looked at the vessels, actually in the image A, they're pointing to the pointing with the arrow, a very soft hypodense plaque here on the right, ICA right at the bifurcation. And when they did special vessel wall imaging, and it's really called a black blood sequence, they found that this plaque was actually ruptured and had hemorrhage in there. So again, we don't really routinely do specialized vessel wall imaging for these patients. Is it something that we should definitely be looking at? Possibly. Malignancy as a potential source happens in about 10% of ESUS patients. When we work them up and do CT, torsos, chest, abdomen, pelvis, we do see patients who may have some risk factors like weight loss, night sweats, fever, tend to present with ESUS stroke as an initial presentation of their malignancy. Again, the pathophysiology could be hypercoagulable, non-hypercoagulable related mechanisms. They do tend to have less of vascular risk factors. They tend to be recurrent and may have high D-dimer levels on presentation. But again, malignancy workup should be individualized. I wouldn't do CT torsos on everybody who has ESUS stroke unless I'm concerned that malignancy may be playing a role. Again, the underlying mechanisms for ESUS and cancer are really hypercoagulable, non-hypercoagulable. Hypercoagulable could be non-bacterial thrombotic endocarditis, paradoxical embolization. Non-hypercoagulable causes can be aortic atheromas, cardiomyopathies, infective endocarditis. So all of these can really present with ESUS strokes as well. Some other rare causes of ESUS. So pulmonary AVMs, and again, not many clinical trials or studies have looked into this as potential source, and it's definitely one that could be thought of as something that can produce or cause an ESUS stroke. What really happens is that there's a low resistance and a high flow between pulmonary arteries and vein, and that can lead to cause shunting, and thrombosis can happen through either like venous thrombosis, bacteria, or other materials that can cause strokes. So again, this can be a potential source as well. Cavernous carotid aneurysms are thought to emboli as well, and obviously intracranial arterial aneurysms can be a potential source as well. So these are rare, but we do see them in our clinical practice. So what do you do with when you think that a patient may have ESUS? So you're either suspecting a cardioembolic source or a non-cardioembolic source. If you're suspecting a cardioembolic source, then obviously a transesophageal echo, CTA chest to look at AVMs, bubble TCD, long-term EKG monitoring, loop recorders, and special testing like ProNPs and cardiac MRIs can be potentially done depending on the individual case. And if you're suspecting that this could be a non-cardioembolic source, then look at the vessels more closely. Maybe the patient needs a more specialized vessel wall imaging. Or could it be underlying malignancy that is the potential cause? So moving forward with the treatment. Now, when we have atrial fibrillation as a potential cause of ESUS, we generally tend to put these patients on anticoagulation. The idea behind anticoagulation is actually not to treat the atrial fibrillation, but more so in the prevention of forming a clot due to the uncoordinated heart rhythm. So many people have argued that if atrial fibrillation leads to embolic strokes and has about 60 to 70% decrease in recurrence of stroke if we put them on anticoagulation, would it be better to just prophylactically anticoagulate these patients who are presenting with ESUS? And would these patients respond to anticoagulation in the same way that patients with atrial fibrillation do? So up till now, 3 clinical trials have actually looked at it. And the first one, again, the first 2 were both Canadian studies, Navigate ESUS and Respect ESUS studies. So the first one, the Navigate study, really compared rivaroxaban to aspirin. So one arm received aspirin only, the other arm received rivaroxaban or placebo. Again, the criteria for enrollment was quite straightforward. They needed to have an embolic looking stroke, and again, at basic or baseline imaging, baseline testing had to be negative for any potential source. They followed these patients for about a year. They enrolled about 7,000 patients, and the trial was stopped early because on initial analysis, no significant difference was seen in the 2 arms. So compared to the aspirin group, where their recurrence rate was about 4.7%, Xarelto or rivaroxaban just was really non-significant in reducing the stroke risk. However, what was interesting was obviously a significantly higher risk of bleeding was seen with patients who were in the rivaroxaban arm. Similar to the Navigate study was the Respect ESUS study that looked at dabigatran versus aspirin. Again, quite similar enrollment criteria. They followed these patients for about a year and a half. Again, no significant difference was seen between the 2 treatment arms. So the arm that received Pradaxa, the stroke risk was about 4.1%, while the aspirin group had about 4.8% per year stroke risk. The Atticus was the more recently concluded clinical trial. Actually, this was presented at the recent Stroke Organization conference. This compared Eliquis or apixaban to aspirin, and in addition to the basic stroke workup that you need for ESUS diagnosis, they also included patients specifically who had a larger left atrial size, more than 45 millimeters. They had and all of these certain features on their cardiac echo to be eligible to be enrolled. Their endpoint was that if there's new DWI lesions on the MRI, and again, this was presented more recently, again stopped early because no significant difference was seen between the 2 groups, between Eliquis or apixaban and aspirin. Arcadia is a trial that we are also a part of here, and it's again comparing apixaban to aspirin. But it's specifically looking at patients who may have, as we discussed previously, atrial cardiopathy. Again, atrial cardiopathy has been shown in various studies to be a potential source of embolism. So again, they pick up more specific patients who qualify maybe according to their BNP levels, their left atrial diameter index, and all of those features on the echo. And again, this study is ongoing currently and hoping to reach enrollment soon. Just a brief summary of all the trials that compared anticoagulation to just a single antiplatelet agent. Navigate, Respect, Atticus, all three really did not show any significant benefit of putting these patients on blood thinners when compared to aspirin. Navigate did show that rivaroxaban had a higher incidence of bleeding. That's why I personally don't prefer switching these patients to Xarelto that often, but that's what the data really showed. Interestingly enough, if you look at it in a different way, it was these anticoagulation or rivaroxaban, Pradaxa, or Eliquis, these were not inferior to aspirin as well. So even though they do carry a bleeding risk, but it wasn't like the stroke risk was way too high in these patients when we compared them to aspirin. So it's just another way to look at it. So based on these clinical trials and some other evidence, how does American Heart Association and Stroke Association recommend treating ESUS patients is a level 3, and the quality of evidence is really low, and they generally recommend that these patients should not, or it's generally not recommended to put these patients on anticoagulation. A single antiplatelet therapy is generally fine. And there have been other clinical trials which have looked at Brilinta as a potential medication as well, and hasn't shown too much of benefit either. So according to the current trials and guidelines, it's generally not recommended to put these patients on anticoagulation. But again, every case is different and guidelines are there to follow, but clinically things can be different. So what to do if we can't anticoagulate them? So obviously, the most important thing before putting patients on any sort of treatment is to really keep on looking for the source. That's really important. You may not be able to find it while during the hospital stay, but keep on looking for them even in outpatient follow-ups and everything. So there have been 2 clinical trials that have compared dual antiplatelet therapy to single antiplatelet therapy. The more older one was a Chinese study, the CHANCE trial, and they basically looked at patients who had minor strokes or TIAs and put these patients on 21 days on aspirin and Plavix versus just aspirin alone. And it did show that there was a significant increase or a decrease in the risk of recurrence of stroke in the dual antiplatelet arm. This was compared, or this was actually confirmed by the more recent POINT trial, and that put patients on dual antiplatelets for 90 days, and then basically compared the 2 arms and found similar results, that the dual antiplatelet therapy group was actually better as compared to single antiplatelets, reminding everyone that these patients were minor strokes, NIHS less than 4, or high-risk TIAs. These weren't disabling or larger strokes. One interesting finding was that obviously, as expected, dual antiplatelet therapy did have higher chances of hemorrhage. However, this hemorrhage risk was more so as you continued the therapy for 90 days or beyond. But the significant risk reduction of stroke was found to be in the first 21 days. So basically, current guidelines or recommendations really say that you should put these patients on 21 days for 21 days on dual antiplatelet therapy, and then choose a single antiplatelet agent after the 21 days are over. The second thing that we should definitely do is monitor these patients for atrial fibrillation. And as discussed earlier, the longer you monitor, the more chances you have of picking up atrial fibrillation. as well. Again, what really remains unknown is what is an ideal duration of monitoring in these patients. Some say 30 days, some say 3 years. What happens after 3 years if you still don't pick up? Does that reduce your risk of having AFib? Still unknown. Still, studies are looking at that. And again, what we usually do is we generally tailor our duration to everybody or every specific patient. So if it's a younger patient who has a low likelihood of AFib, I would rather do a 30-day monitoring or a 14-day monitoring in that patient rather than a 3-year link recorder monitoring. So it has to be individualized. What do you do when you find atrial fibrillation and stroke? And everybody's answer would be anticoagulate them. But interestingly enough, most of the clinical trials that have looked at secondary prevention after atrial fibrillation is found has really included patients with clinically apparent AFib. So not the paroxysmal ones or brief runs of AFib, asymptomatic ones. They have mostly looked at patients who had clinical features or their duration was on the higher side of the AFib. And those were the patients who they put on anticoagulation and found that about 60 to 70% of these patients had a reduction in their stroke risk. But generally what we do is when we hear AFib, or even if there's paroxysmal runs of AFib, most of the neurologists, including us, I think all of us really feel comfortable in putting these patients on anticoagulation. There are 2 ongoing clinical trials, Artesia and NOAT, that are specifically looking at these patients who have subclinical or paroxysmal AFib and then compared them with the clinically apparent ones and see what the risk reduction is. And then the question about PFOs. So PFO, as I discussed earlier, is very common in general population, and again, all of this should be really individualized according to every patient. Numerous clinical trials have been done in the past without any real good answers, but RESPECT and REDUCE are the more recent ones that have shown some benefit in closing the PFO. Obviously, these trials are difficult to do because of low enrollment rates. You monitor these patients for a longer period of time. There are greater chances of patients being lost to follow-up, and all of these trials have shown that there are a really small number of outcome events that happen. So the ROPE score is really a score that we use clinically to when we find a PFO. And we put this on the patient, and we basically find out, is the PFO really the cause of the stroke? So various different factors in patient history, the type of stroke. The higher the score, the more chances are that PFO is actually the cause of the stroke, and rather than other sources of embolism. So if a patient doesn't have any vascular risk factors, like no hypertension, diabetes, does not smoke, and has a cortical infarct on imaging, the ROPE score will be higher, and then you can be a little more confident in saying that, hey, the patient may have, the PFO may actually be the cause of the stroke. And more recently, and this is very recent, people, so Jeff Saver and people in Boston came up with this Pascal classification where they really looked at all the clinical trials that were done regarding PFO closure and stroke, and came up with this classification, which really divides patients into either unlikely, where the PFO is unlikely to be the cause of the stroke, possibly the cause of stroke, or probably the cause of stroke. And they found that they basically combined the ROPE score along with the PFO features, and they found that those patients who had a higher ROPE score and a high risk feature on PFO had about a 90% risk reduction in their strokes if their PFO was closed. So this I think study has been more of a game changer, and we're moving more towards individualizing patient population and then involving multidisciplinary teams, including cardiology and everybody, and finding out what the best approach for these patients would be. So with PFOs, seems to be more related to the stroke if it's a young patient who has an embolic appearing brain infarct. Well, my patient that I initially discussed could have had an embolic infarct secondary to a PFO. Don't have any other vascular risk factors, and the risk features of the PFO are on the higher side, so greater right to left shunting, a higher or a larger septal aneurysm, etc. Arcadia, as I discussed earlier, specifically looking into this cause, the atrial cardiopathy, and hopefully we'll have answers on it soon. Would anticoagulation benefit in these patients if we don't pick up AFib, but the patient is at risk for having AFib? It needs to be seen. So in the end, really cryptogenic strokes I think it serves as a knowledge gap still for us, where a lot of research is still needed. A lot of selecting the right patient population is needed for these studies, because this is a very common cause of stroke that we see in our clinical practice. And even though the clinical trials haven't really shown any benefit in putting these patients on anticoagulation, we may need to readdress that. And as I said, we may need to choose the right patient population in putting or enrolling these patients into these studies. And also, you can always look at it from the other side, that the anticoagulation was really non-inferior to aspirin, rather than really harmful, except for rivaroxaban, which showed a greater risk of bleeding. Certainly, dual antiplatelet therapy should always be considered if a minor stroke has happened or a patient is coming with a high-risk TIA. That has certainly proven to be beneficial in these patients. And again, more recent data has been moving towards readdressing PFOs and picking up the right patients to close these PFOs and to reduce the risk of recurrent stroke. Again, more clinical trials are needed. Maybe more specialized vascular imaging is needed, more vessel wall imaging techniques that can pick up those high-risk plaque features that I was talking about previously. Maybe we need to do more cardiac MRIs to look at the heart better, or more specialized techniques to evaluate the heart rather than just a transesophageal echo. And again, it'll be interesting to see what Arcadia shows. So keeping our fingers crossed, and thank you for joining us. This boy helped me out a lot with the presentation, so just wanted to include it here. All right.
Thank you, Dr. Hasan.
Thank you so much.
Can you hear me?
Yes, I can.
This is Dr. Friedland. Thank you for your excellent presentation.
Mm-hmm.
Did you believe that the part of the body affected in your case was only in the retina, or was it both the brain and the retina?
Just the retina. So it did turn out to be a branch retinal occlusion in this case.
You should have been able to show that clinically by a neurological exam. If
we
it's
did.
Retina,
So initially, when we did the fundoscopy and asked ophthalmology to evaluate the patient, there were no signs of retinal occlusion seen on the exam. And this did a very specialized test in the ER. But 2 weeks later, he did show, when he followed up with ophthalmology, there were clinical signs of branch retinal artery on exam at that time. But initially, there was no. He was actually cleared by ophthalmology.
but you knew by the examination that the only problem was in one eye. Is that right?
Yes, absolutely. And that's why we offered acute intervention, right? I did offer EPA because I was concerned that this may turn out to be a retinal issue, and he refused.
Very good, thank you. Also, as I've discussed several times, the bacteria and microbiota can play a role in stroke, which is a large topic, but the only one I would point out here is trimethylamine and trimethylamine oxide produced by bacteria in the gut influence the aggregation activities of platelets. and has been shown by various workers at the Cleveland Clinic, particularly Hasan and colleagues, to be involved in heart disease and also stroke.
Interesting.
And it's likely that this could be responsible for some cases of ESUS, that if they have bacteria that happen to make more of this than other, they'll have a more likely situation for coagulation, and that there are developing remedies to influence the production of these molecules in the gut by bacteria that could have a role in the prevention of recurrent stroke.
Interesting.
I'll share these papers with you.
Absolutely.
Thank you
Any
so
other
much,
comments?
Dr. Hasan.
Mm-hmm.
Wonderful review and wonderful information for the residents. We do record this, so this will be available to those people who were not able to join us today.
Okay.
Thank you.
Yes. So Hannah has a question.
Okay. So in the city where they evaluated the duration for being on like the cardiac monitoring dial patch for 3 years, did they include like structural deafness, like for example, on even a mild LAD, for example?
Yes, so they did. They had a certain criteria where patients only, greater than 50 were included in the study, number one, because the risk of having AFib goes exponentially higher when you're older. They excluded younger patients. They specifically looked at only the transthoracic echo findings, though, not the esophageal, where they had to have a certain, volume index of the left atrium before they enroll these patients into the study. So definitely yes. And obviously that's why I think they picked up more or a higher number of AFib in these patients, because there's a high risk.
And if they didn't pick up, say that they did have met the criteria, they did have the LAE enlargement, but they didn't pick anything up in 3 years, and you said good more years.
That is a question that remains unanswered. The exact duration of monitoring is really unknown. What do you do after those 3 years, right? So we don't know yet, and again, has to be individualized.
And the study was just like to as normal as possible without anything cardiac induction.
Correct. Correct. Absolutely. Yes. All right. Okay, I think Dr. Emil, I don't know if anybody else has a question.
Well, then we look forward to spending a little more time thinking about this with our cardiology friends as well.
Yes, and I think we're working on it, right? Especially with the
Yes.
PFOs and these strokes. So just to let everybody know, we're deciding on a monthly conference where we'll be joined by our cardiology colleagues, especially structural cardiology, and we'll be discussing these cases with them and finding out and coming up with a plan that what the best plan moving forward for these patients is. So we're really excited about that, Dr. Emil.
Yeah, this is a great opportunity. Wonderful for the patients.
Yes.
So thank you very much. Great job. We will see you soon. Thank you very much, everyone, for joining.
Okay. Bye-bye. Hey, what's up?